Okay, so in today's class, we're going to talk about the maternity. And maternity is the second most favorite subject for the NCLEX RN examination. So I highly recommend it to study this whole maternity very nicely. The topics in these presentations, definitely they are important, but I still highly recommend it. Apart from these topics, whatever you can study from the Sounder's book, it's a great idea. And you can do the questions at the back of each chapter also. That's another great idea too, because as I said, maternity is the very important for the examination. Now, let's get started with the first topic for today. The first topic we're supposed to do is the pregnancy signs and symptoms, right? So in the pregnancy signs and symptoms, why do we need to know them? Because sometimes the NCLEX can ask you a basic question as well, like what are the presumptive signs of pregnancy, probable signs of pregnancy, or even the positive signs of pregnancy, because we do have 3 different signs of pregnancy, right? And it's very difficult. Sometimes students cannot remember in the examination for an easy question. And it's a select all the type of apply type of question. So I will only recommend to do these symptoms, remember them with the acronyms, because that will be easy job for you to recall them in the exams. Now, before we do the acronyms, let's try to understand what is presumptive sign of pregnancy, right? Because if you don't know the meaning, then you don't know what to look after, right? So presumptive sign of pregnancy means presumptive means assumptive, assuming assumption. You know, that's how you can recall it. So this is something when a woman, she thinks, she assumes something, you know, at home, oh, I might be pregnant, you know, and that is we call presumptive signs of pregnancy, because that's something you assume it by looking after your body changes, or maybe you felt something in there, right? So those signs are, first of all, missing the periods, which is the most commonly the women's when they don't have the periods at the regular time. They're thinking they might be pregnant. So this is we call amenorrhea, or they're feeling very tired. The body is getting tired, or they see some changes in their breast. Maybe their breast is going to be enlarged for them, or some sores. Now, sometimes these signs, enlarged breast, sore breast, that can also be a sign of PMS as well, like your periods may be coming, right? But if you're feeling your periods miss at the same time, or you're tired at the same time as well, or you have more than one symptom in here, that could be an indicate the person may be pregnant, right? Most commonly, I would say the women start going to used to the washroom again and again. So frequency of urine is very common, right? And apart from them, they feel nauseated, vomiting most of the time, because their hormone HCG level is increasing inside the body, and that makes the woman feel more nauseated. Now, sometimes, very rare, but not all the cases, the woman might also can feel some movements inside the tummy, inside the body. That is what we call quickening movements, you know, and that is how when it is happen, when they feel the fetus. Now, how do they feel the fetus? When do they feel the fetus? So usually the woman's like the one who does has a problem like PCOS type of conditions, right? Maybe they don't have the periods on the right in the right time in the regularly. So sometimes the periods are irregular in PCOS, and they don't know, they are not aware about that they are pregnant already, right? Because sometimes the periods is still there in between because of the PCOS, and then they don't know the periods has not been missed, so maybe they don't know they're still pregnant. So it's rare chances, but it has been noticed as per a lot of research that the woman can feel some fetus movements at that time, and that's how they know that they become pregnant at that point. So this is what we call presumptive signs of pregnancy, where the woman can see their body changes and they feel something, they might be pregnant, right? Now moving on to the next part, which is probable sign of pregnancy. Now, if you feel like in between pregnancy anywhere that something you don't understand, or you want me to repeat it back again, feel free to stop me in between so we can discuss more about it, about the same point. Otherwise, I'll move on to the next one for sure. No worries. So probable signs of pregnancy means, probable means like Now you know you're pregnant, but you not have actually seen the fetus yet. Maybe you felt something, from outside the tummy, but you did not actually visually see the baby inside yet, or did not even hear the heart rate yet, right? That is we call probable sign of pregnancy. So here the women, they do the pregnancy test, even in the house, even in the hospital, everything comes positive, so they know they are pregnant, right? Or maybe the doctor check their tummy, they do the assessment, right? And they feel the baby positionings and everything returning from one place to another. So which is we call ballotment. They check the outline of the fetus as well, right? So that's how they know, that the doctor know, they can feel something. Yes, you're pregnant. We can see something inside, right? But we did not actually see the baby from inside yet, visually, right? Or sometimes the doctor, when they do the assessment of the cervix, right, they see some changes on the cervix too. There might be some softening of the cervix, or maybe some color changes of the cervix, or maybe the uterine segments become really soft from inside. So this is what we call Goodell sign, Chadwick sign, Hagar sign. These signs are common in case when the doctor see the changes on your cervix, and this is 100% going to be noticed for sure because of the blood circulation, what's in there. And the Braxton Hicks contraction, that's another thing what indicates the possibility of the pregnancy over there too. Braxton Hicks contractions is basically, I would say in a one word, this is a false contractions basically. False contractions means this is basically happen after the mid of second trimester, when the baby develops already a lot, and right before the pregnancy. It could be anywhere where the mother feels some contractions, but it's not actually the contractions. This is something, a false labor sign, right? And how do we know this is a false labor sign? We usually know when the mother changes position, the contraction will go away, right? So when she was like in standing position, she can sit down, the contractions will not be there. Or maybe she sit down already and the contractions start and she start walking, the contraction will go away, right? So basically in Braxton Hicks contraction, the contractions basically reduced, or you can say the severity of the contraction get reduced or decrease, or just go away with the time once the mother changes the position. That is how we know this is a false labor sign, which we also call as the Braxton Hicks contractions. Enlarged uterus, maybe a large uterus is there, not maybe, I would say it's always there, because the baby size is increasing inside the body, and the baby needs a more space in the uterus. So the uterus will start becoming enlarged, at the same time. And definitely the mother, you can see the mother physique and the mother weight changes as well. And that indicates the probable signs of the pregnancy in that case. Now, so far, we did not see the baby actually yet. That's why there is no positive sign of pregnancy yet, right? Positive sign means like you actually watch the baby or you hear the baby sounds, right? So in the positive sign of pregnancy, the first thing we have is the fetal heart rate. So you will actually see the fetal heart rate either on the screen, the one they do your ultrasound, or you can hear it by using a Doppler when the doctor is using it. Usually they do your assessments like once you become pregnant. So after 10 weeks, they start checking your fetal heart rate regularly in the ultrasounds also. And that's how you know this is exactly what you hear and the baby's in there. And that's the positive sign of pregnancy. Or the another positive sign of pregnancy, I would say, is the active fetal movements. The baby is moving inside a lot. When the examiner is like trying to doing the ultrasound, they actually see on the screen that the baby is moving inside. On the screen means the screen of the ultrasound. When they do the ultrasound of the mother, they can watch the baby actually in there. Or the normal ultrasound, even if they go for it, but they don't want to see the baby completely movement in there, maybe baby is sleeping, but they still see the ultrasound is there, the baby is inside, the head, neck, everything is in their legs, that's how they know it's the positive sign of the pregnancy. So the difference between, once again, is the presumptive means it's kind of like assumption, but you're thinking you may be pregnant. Probable means you know you're pregnant for sure because you already test positive in here. But the only difference is you do not see the visually baby yet. And in the positive sign of pregnancy, you actually see the baby now. And now you know this is there for sure because you see it already. It's not just a feeling, right? So this is we call the pregnancy sign and symptoms. Any questions until here? Any questions until here, Princey? Just want to make sure you're still here on the screen. Okay, I hope my voice is still audible and you can still hear me. I'll move on to the next topic in the meantime, which is the Naegele's rule, but you can always let me know in between if the voice is not, if something is not clear. Moving on to the second topic. The second topic I'm going to discuss is the Naegele's rule. I'm not going to do this question first because we need to understand what is the Naegele's formula or Naegele's rule or Naegele's rule, however you want to pronounce it. This is the rule basically to check the estimated date of delivery, right? Estimated date of delivery. Now, how do we find the estimate of delivery? So to find that, you always collect the history from the mother and ask the mother, when was your last menstrual periods, right? And the mother will tell you like it started on this date and ending on this date. So whatever the date she gave you as a first date of the LMP, which means the starting date, right? That is how you check the expected date of delivery from there. So for example, here the mother give you in the question the first date was the October 19, 2018. So I'm going to use the same example so we can hit the question at the same time. October 19, 2018. Maybe mother says my first period started at that time in the last menstrual period. Now what you do in here is there is a formula, you minus 3 months, right? You minus 3 months and then you plus 7 days, right? Then you plus 7 days and then you plus 1 year into this. A lot of people don't use the formula, they just calculate by 9 months method, they just plus 9 months from here. But if you want to go that way, you can. But if you feel like to use the formula, excuse me, I'm sorry. If you want to use the formula, you can also use the formula as well. So the formula is minus 3 months plus 7 days and plus 1 year. So minus 3 months means, so the date what she gave it to you, October 19, you minus 3 months from here. So the easiest method I always tell the students, pick your options first. And in the options, if you see there is something July, something August, you try to see 3 months from there. So if I do 3 months from the August, that will be September, October, November, right? That will be November, but they give me October. That means I have to go to July only, not the August option. So July, if they give it to you, that will be July, August, September, October. So August, September, and October. That means 3 months from July will be October, right? Now, once you know the estimate idea, this is the July month for sure as a 3 months, then you plus 7 days is in there. Just give me 1 second. Sorry, my screen was tilted before. Then you plus 7 days from there. So plus 7 days means plus from 19th, right? So 20, 21, 22, 23, 24, 25, 26. That will be 26th of the July plus 7 days. And if you plus 1 year, that will be 2019 from 2018. So that means the answer for this question is letter B, July 26, 2019. Again, this is just a formula method to calculate it. Once in a while, NCLEX can give you these type of questions too in the exam, and I would highly recommend not to miss these type of questions because they are easiest question to tackle it, right? Again, if you don't understand any topic in here, you can stop me in between, and that was the formula for the Naegele's rules, and that's how we do this type of question. Moving on to the next part, which is the gestational diabetes mellitus. What do we need to know in gestational diabetes mellitus? So first of all, gestational diabetes mellitus is basically when someone is diagnosed diabetic during the pregnancy stage. And when does it occur? It usually happens in second and third trimester. of pregnancy, because pancreas is not responding enough to the demand for more insulin at that time, right? So because of that reason, the um, mother will be like diagnosed as a positive with the diabetic in that stage. Now, in that mother, how do we know she's diabetic? So to do that, we actually check one of the tests, which is the glucose tolerance test, GTT, glucose tolerance test. That glucose tolerance test is basically for 3 hours test, which we need to do it to confirm the gestational diabetes mellitus. And how do we do this test? We just simply ask the mother to at least 2 to 4 hours like NPO. If she cannot be NPO because of pregnancy, then at least no sugar for 2 hours at least before she come for test in the morning. So when she come for test in the morning, we take the fasting glucose testing first and then see what's the sugar level look like. So you take the blood sample and then you see the fasting levels of her, and then you give her a drink of glucose to drink it, like about 500 ml, I would say. We give her liquid to drink after the baseline value you got it. And then once you drink that bottle with the glucose inside, a lot of those glucose are safer in the market because they're only meant for the test purposes, not to increase your blood sugar. So like in India, there's a Glucon-D. I would say that's the example. And in the outside, in Canadian or States country, they give you like vitamins kind of drinks to drink it, which has a glucose inside. And it comes with a flavor also, like strawberry, oranges, those kind of things. So anyways, they give you that drink, 500 ml. And once you drink that drink, they take your second blood test at least 1 hour after you drink it. And then after that, they match your both values together and see if your blood sugar is high after drinking this liquid or not. If it sounds high, definitely sounds as a positive gestational diabetes mellitus, but if it's not high, it still stays normal. That is something we call negative results, right? A lot of time, who are the women who will be at the risk for this thing? I would say the one who across the ages like 35 plus in case of pregnancy, and also usually the who are really obese, multiple gestation also, they had a pregnancy earlier, or maybe sometime it's in their family history, especially from maternal, like mother or father was diabetic before. Now, when you see this mother in a clinical presentation in your emergency area, how do you know she is a gestational diabetic? So she will tell you some sort of symptoms. So she will be more likely thirsty, more hunger, more urination, more blooded vision, if especially the blood sugar is very high, or sometimes there's a lot of chances for infection in there, not just the UTI, but it could be like multiple infections she's getting again and again. Or she does have a coexisting conditions. Maybe it's a high blood pressure, and because of that, now she's diabetic. Or maybe the baby inside, it's too large as per her age right now, because the baby is consuming more sugar in there. That's why the baby seems more bigger in there as per the gestational age at that time. Or maybe there's a lot of fluid around the baby. That actually does the same job. So polyhydramnios can also be there as well. But how do we treat these mothers? You just simply go over the diet with them, tell them to do some regular exercise, maintain their blood sugar as much as possible, and always observe for the signs of hyperglycemia, hypoglycemia, and ketonuria into them. So I'm going to teach the mother basically watch for these symptoms even at home once they get discharged, because at some point these symptoms can be presented and they need to know where to go in hospital and when. And always check their weight level as well, because the more weight will be there, the more chances of the blood sugar as well. And you also want to see the blood pressure at the same time, maintain blood pressure at the same time. Just check for signs of preeclampsia, eclampsia, and check for infection, because high chances of infection means high glucose inside the body. And you also want to see the fetus at the same time and check for fetal compromise symptoms as well. Like maybe the fetus is not doing well with the breathing in terms of breathing. So always check your fetus during the journey of the pregnancy. But that was just the normal intervention. What do we do with the mother overall? But if I talk about in terms when the mother is already in labor and in the last stage, when the baby is about to come out, at that time, the main important thing is not just to check the fetus continuously, but you also do some medication treatment during the labor time. because during the labor time what happen is the glycogen is getting depleted a lot with a lot of bleeding. So at that time we give the mother IV insulin, right, and also the IV the glucose as well. So we need to give both together, not as a separate. The reason for that is because we don't want the mother to go into hypoglycemia with a lot of bleeding and a lot of insulin only, right? So you also give the sugar at the same time and put the sugar down slowly, slowly in the mother, not suddenly. We never put the sugar down suddenly in the mother. We always go slowly, slowly as well. And apart from that, when she is already delivered the baby, she is transferred now to the postpartum stage. At that point, you always check for signs of hypoglycemia, not just for the mother also, I would say for the baby as well. Because the baby before, when it was inside the mother's womb, the baby was consuming more sugar actually. Now it's difficult for the baby not getting sugar, so more chances for hypoglycemia, especially within first 24 hours. So signs of hypoglycemia needs to be checked at that point, and even the signs of PPH, we always check because more bleeding depletion will be there. If more bleeding, the more chances for hypoglycemia. So these are the most important. What do we do at that time in case of the gestational diabetes? Now, I hope you understand back again that topic. Now we're gonna go to the next topic for today, which is the ectopic pregnancy. So what's the ectopic pregnancy? Ectopic pregnancy is basically, if I show you with the picture first, so I'm just gonna make a zoom of the screen. So ectopic pregnancy is basically, as we know, the normal pregnancies basically happen in here in the uterus. But in case of the ectopic pregnancy, the baby, the ovum, like it's gonna be fertilized actually in the fallopian tube rather than in the normal uterine position. It's gonna be in the fallopian tube, and because of in fallopian tube, the baby cannot grow enough in here. So there will be chances of rupture and ending of the pregnancy in here. So this is what we call the ectopic pregnancy, where the baby, the implantation, if I say the word implantation, it's basically happen outside the uterine cavity. And definitely the fetus is not gonna be survived in here. So in the terms of medical definitions, it's the implantation of the fertilized ovum outside the uterine cavity. And as I said, the most common will be fallopian tube. And which part of fallopian tube will be more common? That will be ampulla, right? Now, if I go for assessment, what do we do in that stage? How do we look for the mother is really having diagnosed ectopic pregnancy? Well, I would say the missing periods you're gonna find in everywhere, but that doesn't tell you this is ectopic pregnancy for sure. But there are some symptoms which exactly tells you and differentiate that this is ectopic pregnancy, which is about she will be having a severe abdominal pain, especially if it's get ruptured already. So when the rupture has happened, the rupture pain will be there, but also she will be having a severe abdominal pain and she's bleeding at the same time. And the bleeding always, when you collect the history from the mother, you will get to know it does not start it suddenly. It starts with the vaginal spotting first. So vaginal spotting will be there, then bleeding will be there, and usually the blood in this case will be dark red and brownish in color, not normal red. It's a dark little bit in there. Sometimes the mother also see, I would say, if the fetus is already there about 10 weeks already or 12 weeks already, because usually it ended up before 12, 13 weeks. The gray color, the fetus, the grayish, bluish type of thing, they're also gonna see, and some tissues inside as well. So this is how you collect the history from the mother and you figure out if she really has been diagnosed with the ectopic pregnancy. But now what do we do for her? We can do some vital signs for her, definitely, right? Because you know the signs of the shock can be presented. So very important to check the blood pressure, heart rate for sure, and you keep checking for bleeding. And you make sure you get the order for methotrexate and give it to the mom. Because you don't want the cells to get divided further. And sometimes not everything has been removed from her, so she might need to end up in going for surgical removal as well. Apart from this, the medication keep continuing with the antibiotics because the infection chances will be more in here. And if the mother is Rh negative, she might need the Rhd immunoglobulin if the fetus was before as a positive and mother was negative with the Rh incompatibility. So in that case, you might need to give the Rhd immunoglobulin as well. So that was all about the until ectopic pregnancy topic. Now this topic I'll discuss later in there. Just give me 1 second. Next topic I'll discuss first is the postpartum hemorrhage. Then I'll go back to the other topics later. Now, what is the postpartum hemorrhage basically? As we know that with the name, it's basically excessive bleeding, right? If the mother has an excessive amount of bleeding, we need to look something in there. And this can happen at any stage once the baby gets delivered. Usually it happens within first 4 days, but it can happen at any point. But what do we do as an RN in that case? That's something we need to know for sure. Because if we don't know what to do in that situation, we don't know then how to pick the answers. So the very first part is, I would say, notify the doctor and stay with your patient as well, because your patient is bleeding. You need to call someone for help. But before you call someone for help, can you do something as an RN? I would say yes. The very first step, I'm repeating back again, the very first step you do when someone is bleeding in case of the postpartum hemorrhage and you know that the patient is bleeding, or maybe in the question, they did not give you postpartum hemorrhage, but they're already telling you the mother uterus is atonic, or maybe they're saying the mother uterus is soft, or maybe they're saying the mother uterus is boggy. That means there is no uterine contraction inside the uterus, and that leads the patient bleeding a lot. So if they give you these kind of terms in the question, that indicates the patient is having excessive bleeding. Remember, in that case, your first nursing action in those cases in PPH, massage the fundus immediately. Massage the fundus immediately. I'm repeating. Do not call the doctor first. You can massage the fundus first by yourself as an RN before you call the doctor, right? Once you start massaging the fundus, why are you massaging the fundus? Because you want to make the uterus to contract. And with the contraction, it's going to be stopped as well. So basically massage the fundus first, right? Sorry, you're saying something, Princey. Can you unmute back again?
Boggy uterus.
Yeah, boggy uterus, yeah. So the uterus is boggy, soft or atonic. You need to massage the fundus immediately in that case as the first thing. Is that was something you were saying?
Yes.
Okay. So now if the fundus they give you firm, remember the firm is normal. In that cases, you do not do massage the fundus, okay? But sometimes the NCLEX can make you confused. They can say the fundus is firm, but the patient is still bleeding. If the patient is still bleeding and the fundus is still firm, I would suggest call the doctor first in that case, because you do not need to massage the fundus because it's already contracted, it's already firm, right? But if the fundus is boggy, uterus or soft, they give you atonic, then definitely massage the fundus first, and then second step is call the doctor, right? Now, before call the doctor back again, sorry, I already mentioned it's the second step, but can I do something else before I call the doctor again? Definitely, you can do a lot. You can change the position of the mother. I would say left sideline position is recommended. That is something you can do right away. You check oxygen for her and give her oxygen if it's required, and then call the doctor. So I'm going to repeat these steps back again because it's not really in the books. They organize something in there. The first step is massage the fundus. Second step is positioning. Number third is oxygen. So don't go for oxygen first right away because you want to give positioning first to be effective before you apply for the oxygen, right? And we don't do the vital signs in here before we call the doctor because vital signs come as a priority later on. By the time your team is coming PPH, it's a PPH code. now, which you need to supposed to do or call someone for help or call the doctor because it's an emergency. So by the time your teams is going to be arrived, we can do the vital signs at that time. So vital signs can wait because this is something you should already know with the knowledge that if someone is bleeding, the blood pressure is already low, right? So don't waste your time in checking blood pressures and everything in here. So vital signs can wait, right? So massage the fundus and then positioning and then oxygen, right? Then call the doctor as a number 4. And once you're done the call the doctor, then you can do some other stuff like fifth action, like vital signs, and you can start some other uterotonic medication to stop the bleeding. And these medications we'll talk about in later in our next class as well in detail, what are the oxytocins and everything. So these medications, they actually help in stop the bleeding. And with these medications, we're not just going to give them alone. We can give some IV lines as well. Like IV line, I would say the normal saline is recommended, but lactate ringer solution could be a great idea, another one, because your patient is already going into hypovolemic with a lot of bleeding. And sometimes the patient bleeds a lot, so you might need to administer some blood products as well and insert the catheter, urinary catheter in there to monitor the perfusion and administer the emergency medication, whatever required as per the patient condition at that time. That's what you're supposed to do. And maybe you prepare your patient for emergency treatments as well if it's bleeding a lot, and keep documenting continuously and also documented at the end as well. So that's what you do in case of the postpartum hemorrhage, or if your patient is bleeding by looking into the fundus, you feel like it's soft bogey or atonic. So this is what you're supposed to do as a part of the nursing action. Now, let me see what other topics we can cover up today at the same time, and then the rest we'll leave it for tomorrow. The next thing I'll discuss maybe in here is let me see, I'm going to talk about the eclampsia and preeclampsia. Not from this question, but I'm going to discuss this topic as a part of the general. So what I'm going to do is I'm going to pull like an empty slide with me so I can make some notes in here. And it's not a thank you message yet for sure, because we still need to discuss eclampsia, preeclampsia. For that, I highly recommend it to follow the book, because the book already give a lot of information about what is eclampsia, preeclampsia, and I'm going to read it from there as well at the same time to make it easy job. So now these comes under, if you see your book later on, it comes under the chapter risk conditions related to pregnancy. And in that chapter, you will find a topic, gestational hypertension. Gestational hypertension. In the gestational hypertension, they actually describe really well preeclampsia and eclampsia. So they're trying to talking about that the hypertension can be mild, severe as well, and it can lead in someone to go into stages preeclampsia and then eclampsia. Eclampsia is basically a seizure, a severe stage, and preeclampsia is just like a high blood pressure, but it's not that very high yet in pregnancy. But yeah, it's still something what you got diagnosed in case when the mother was not like high blood pressure before, but now she is. So when I talk about some symptoms, differences between preeclampsia and eclampsia, usually in the preeclampsia, I would say the blood pressures is usually around 140/90 or plus than that. But in cases of eclampsia, it's more than 160/110. So it's a lot of high blood pressure, like 190 somewhere it can be. In preeclampsia, you will also see some proteinuria as well, but not that very high. It's just like more than 0.3 in a 24-hour test specimen, the one you do with the dipstick for the urine. But in case of the eclampsia people, it will be very high, like more than 5. In the preeclampsia, the some of the other blood tests like creatinine, platelets, the everything stays normal. So urine output stays normal as well. Even they don't have any other presenting symptoms like visual problem or anything like that. No heart problems, no cyanosis, nothing like that in there. It's almost absent. They don't even have a headache or mental confusion or any abdominal pain. But if I talk about the eclampsia people, they usually have like very low urine output. Like sometimes the kidneys are not functioning enough, like oliguria is there. And they also have like more creatinine levels as well because their kidneys is affected now. And platelets start getting decreased at the same time, and livers also enzymes gets elevated at the same point. And definitely the patient will present you some symptoms. So they might can tell you I have a headache, mental confusion, and they might can tell you I have abdominal pain, I have a visual problem also, nurse, I can see some blurred vision. So all those things are present definitely in case of the eclampsia people where the blood pressure is more than 160 by 110, and definitely it will also affect the growth of the baby. But not in case of preeclampsia because it just started high blood pressure, which can be treated easily. Now, what are we supposed to do with these preeclampsia and eclampsia? If I talk about general interventions for preeclampsia, you just simply give them like bed rest and tell the mother to be more in the left lateral position and keep checking her blood pressure, weight frequently. And you as a nurse check the neurological status of the mother. Because you know that preeclampsia mom can also go into eclampsia stage as well, or maybe the seizures can be there too. And give her adequate amount of fluid until unless it's not restricted by the doctor, and keep checking her urine output, deep tendon reflexes. And I would give her nice diet, like diet more in protein, carbohydrates, but no salt. No salt is in there, and give her medication, whatever can help in reducing the blood pressure. So this is what I would do in preeclampsia. But if in the preeclampsia, I would say if the symptoms already start getting worse, then definitely we need to introduce a medication, which is the magnesium sulfate, which I'll talk about it tomorrow in the next lecture. Magnesium sulfate is the medication which you can give to reduce the blood pressure. That's something, not about the blood pressure, but to reduce the seizures because it's a CNS depressant medication. So I'll talk about this medication in detail tomorrow again, not today. But apart from that, if I talk about eclampsia mother and she's already in eclampsia stage, what we can do as an RNs in there? Well, I would say eclampsia means seizures. So all intervention, what do you do as a seizures? You stay with your patient, call for help. You keep checking the patient for open airway, do the positioning on the sides. You also check the fetal heart rate pattern at the same time and administer medication, whatever can control the seizure, like magnesium sulfate, as I just mentioned. And once the seizures get ended, definitely look for oral airways, see if something you need to insert at that time or not, or mother need a suctioning or not, right? If secretions isn't there. And I would say collaborate with the doctor and prepare this one for delivery as soon as possible, because most likely it's going to be ended up in going for C-section because we don't have time to go for vaginal delivery in here, and definitely document at the end. So that's what you do in the cases of the preeclampsia and eclampsia stages. And that was a brief information about these two conditions. Now, that's all definitely something for today. The rest I would like to continue tomorrow because the next topic is a little bit huge topics, which I will pull it up tomorrow. And once